Sean is a 45-year-old male with a long history of Crohn's disease. The patient was diagnosed with Crohn's in the upper GI tract at age 19. The patient has had many flare-ups since being diagnosed, along with 4 small bowel resections and a couple minor procedures. The patient sought out treatment due to unresolved colitis, resulting in dehydration and severe pain. The patient just underwent a loop ileostomy to aid in treating his Crohn's. The patient now has a stoma as a result of the procedure. The patient is currently receiving sodium chloride every 6 hours to maintain electrolyte balance and Remicade for his Crohn's. The patient's BUN and sodium are elevated, which makes sense due to the patient currently being dehydrated and considering his procedure. The patient also has a low potassium and high glucose levels. Overall, considering the patient just underwent a surgery, all of his lab levels are within normal limits. The patient is 68 inches, 165 pounds, and has a BMI of 25.1, and there are no other weight histories currently for this patient. Since the patient is at a healthy weight and has a % ideal body weight under 125%, I'll be using his current body weight for recommendations. Also, using the Clinical Nutrition Pocket Guide and the fact that the patient is a normal weight, a calorie recommendation for him would be around 25 to 30 calories per kilogram. However, if the patient starts losing around 1.5 liters of output, energy needs will need to be increased. Protein will definitely need to be increased to around 1.2 to 1.5 grams per kilogram, and fluids will also need to be increased due to the water loss. I'd say fluids would be about 30 to 35 milliliters per kilogram per day. However, depending on losses, fluid needs may need to change. Regarding the weight bias, I did not see any major mention of weight at all really in this case. The patient is at a normal weight, so that may also have something to do with there not being any bias. The RN who did the acceptance note was very brief, got straight to the point. The radiologist who did the abdominal CT scan was very knowledgeable and not biased at all. The MD who did the H&P was very descriptive and only gave us, factual information like previous medical history and current medical history, and then anything else that we needed to know about the patient. There was not a bit of information that had really any bias to it, especially regarding weight. The very detailed surgical report was just a step-by-step rundown of the procedure, so the MD who wrote this report had no weight biases at all. The post-op note done by the RN was not biased either. To me, the whole chart and the whole, all of the clinicians were not biased at all. If there was any bias, I would first address the healthcare professionals and just bring up what I witnessed or what I had seen in the chart. If the bias is constant, I would definitely report it according to our policies at, whatever the facility would be. I would also use professional codes of conduct, such as the Academy of Nutrition and Dietetics Code of Ethics to support any causes. Using motivational interviewing to support a patient who just had a loop ileostomy, it would involve building that rapport and exploring the patient's concerns to help guide them towards manageable dietary changes. I would start by asking the patient open-ended questions to understand how he's feeling about eating and hydration post-surgery, because his recommendations have increased, so this could be very different for him. I would also focus on some key priorities like preventing dehydration, managing that stoma output, and avoiding high-fiber foods. Using reflective listening and confidence scales to explore motivation and readiness for change would also be key in our counseling sessions. I would also try to encourage a gradual dietary progression and monitor the patient's response. Research supports its use in chronic GI care and to improve the adherence and reduce complications post-surgery. So the goal, overall is to support this patient in behavior change in a overall successful way that would build confidence, for long-term benefit. And one effective strategy to reduce weight bias is incorporating weight stigma education into the medical, nutrition, and allied health professionals all around. These programs could address negative effects on weight bias by teaching respectful communications with patients of all body sizes and promote a weight-inclusive approach to care. And patients who receive weight stigma education are more likely to show greater empathy